Ma'am, we are live, ma'am.
Okay. Yeah. Are we live?
Yes, we are live, ma'am. You can share your screen.
Okay. So a very good evening, everyone.
Ma'am, you have to share your screen.
Yeah. So, yeah, I hope my screen is on full
Yes, ma'am, it
sight.
is. You can go ahead, ma'am.
So very good evening, everyone. On behalf of Team YOSI and the Team YOSI Journal Club 2022-2024, I, Dr. Nupur Goyal, welcome you all to the session. And this would be probably the last session of the Journal Club team of 2022-2024. So this was the Team YOSI 2022-24, President Dr. Sonal, Dr. Digvijay, Dr. Devakant, as the Vice President, and the incoming President, Dr. Karan as the current Secretary, Dr. Avnish as a Treasurer, and Dr. Nilesh as a Joint Secretary, backed up by a wonderful team of executives, me and Anujit being one of the team members. So this was a pan-India team who has worked very hard, and we have worked together as a team to bring where YOSI it is. And we now have the incoming team, a very dynamic team headed by Dr. Devakan, the incoming president, Dr. Sonal as the immediate past president, Dr. Karan Bhatia as a vice president, Dr. Nilesh as a secretary, Dr. Aditya as a treasurer, and Dr. Prasanna as a joint secretary. And again, a very dynamic pan-India executive team. So the team will be soon taking over, and congratulations to the entire team, and wishing all the very best for your next 2 years. And so coming to the concept of YOSI Journal Club. So how it began. So, a group of us got together and we thought that, young ophthalmologists in different stages of their career as a postgraduate student, in different stages of their career have different questions with respect to thesis, with respect to journal articles, how to interpret a journal article, how to publish. So with this, we came with the concept of the journal club. And so journal club is basically, it's the how do you go about a researching a literature. So it's the definition of the problem, specification of a research question, definition of the variable, selection of subjects, and a lot of other concepts, and the MARI format, which we'll be elaborating further in the journal club session. So the format of the YOSI Journal Club so far has been that there is a presenter who's generally a postgraduate student or a fellow who presents a journal article under the guidance of a monthly mentor who's a young faculty YOSI member who's accomplished in the respective field. The session is moderated by one of the journal club team members. Then we have a research expert on board who has good knowledge about the biostatistics and gives a statistical critique to the article. And then the article is dissected with respect to the positive, the negative aspects, and the recent advances on the topic by the expert panels in that particular field. So this is the format that we have been following. So coming to the MARI format, so this is a step-by-step analysis of the journal club, which the presenter will be analyzing the article after after she presents the article. So MARI is basically the acronym for the method, assignment, assessment, results, interpretation, and extrapolation. So as I said, this is a step-by-step approach to reading the medical evidence. So this has been the Team YOSI Journal Club for 2022-2024. I've been the in charge, Dr. Anujit being one of the key most members of Journal Club. For I can safely say on whose back the whole Journal Club has done so well over the 2 years. Thank you, Dr. Anujit, for being such an integral part of this Journal Club session. Again, Dr. Rohit Modi, who has contributed immensely with respect to research as being a research expert, Dr. Bharat Gurnani, and the mentors were Dr. Sen Gupta and Dr. Vivek Dave. So this is how we started. We floated a Google form and we created an email ID with which we had presenters who wanted to present, showed interest to this session. And it started way back in 2021 during COVID times under the guidance of Dr. Sonal Kalia, who was a brainchild behind this. We had some wonderful sessions in 2021 covering all specialties, as you can see. This further continued into 2022. Again, various specialties were covered. And then we had a very successful run in 2023. One of the key things that we had in 2023 was a separate session on biostatistics where we gave aspects of biostatistics were discovered by the young ophthalmologist. Also, for the first time, we had the introduction of the IGO YOSI live wire by none other than the IGO editor, Dr. Vanati. And this has very nicely continued over to the next year. We started with the YOSI Journal Club 2024. We had a refractive article discussion in January. And then we had a very wonderful some IGO YOSI live wire sessions on case reports, on photo essays, on original articles. And today we have another wonderful session lined up for you, discussing an interesting Retina article. So coming to today's article, so this is the Tenaya and Lucerne study, which is published in American Academy of Ophthalmology. The journal has an article impact factor of 13.7. And the research expert for today is Dr. Bhavik Panchal, who's a consultant at Anant Bajaj Retina Institute, LV Prasad Eye Institute at the GMRV campus, Visakhapatnam. Then we have a very dynamic expert panel on board. So first we have Dr. Ruchir Tiwari, who's a retina specialist working as a vitreoretina and uvea consultant at Tiwari Eye Center, Ghaziabad and Noida. Dr. Divakant Misra needs no introduction. He's a director and head retina services at Swan Jyoti Eye Hospital, Aliganj, Lucknow. Then we have Dr. Kartikeya Singh, the frequent vitreoretina surgeon at ASG Eye Hospitals, Varanasi. And Dr. Rohit Modi, who's also been a very key member of Journal Club and a very dear friend. So Dr. Rohit is a director of Centra Clinic and Eye Hospitals in Mumbai. So today's mentor is Dr. Ritika Gaur. She's a consultant vitreoretina, uvea and ROP at ASG Eye Hospital. And today's presenter is Dr. Meenal Soni. So she is currently a VR fellow at ASD Jodhpur. So, and I am your moderator for today. I'm currently working as a consultant anterior segment and oculoplasty at Eye Care Eye Hospital and PG Institute, Noida. And so before we go on to the journal article, let me just also let you know that today's session is being academically sponsored by Roche. And we have a sponsored talk on angiopoietin inhibition in DME and EMD by Dr. Anujit Paul. So he's currently a vitreoretina fellow at BBI Foundation, Kolkata. He's also the recipient of IGO Platinum Award in 2021. He was also the recipient of the TNOA Gold Medal in 2021. He has 23 PubMed index publications in national and international journals, and he's presented papers in state, national, international forums, and he's very passionate about ophthalmic education and research. So with this, without further much ado, let's begin, and over to you, Dr. Anujit, for your talk.
Thank you so much, ma'am. Thank you for being one of the main pillars of Journal Club. Without further ado, I will just share my screen. And am I in full screen?
Yes, Anujit, you are.
Yes, Anujit. Right. So thank you so much. So we'll start off this Journal Club in a very different way with a talk on the role of angiopoietin in the retina and the role of angiopoietin inhibition in diabetic macular edema as well as neovascular AMD. A small correction, I'm right now a consultant in BBI Foundation. So as we know, since 2004, the entire spectrum of treatment of retinal vascular diseases has changed dramatically from lasers and cryo in the past to intravitreal injections. We started back in 2024 with Macugen, that is pegatinib, and now we are somewhere on the other end of the spectrum 2 decades later with faricimab. So keeping anti-VEGF in mind, the search continues, and we try to look for another way of treating retinal disorders. Is there a way in which without or alongside inhibiting anti-VEGF, can we go ahead and treat retinal diseases? And that brings us to angiopoietin, its role, and how we can use angiopoietin to our advantage. So in healthy vessels, there is an angiopoietin 1 and tyrosine kinase signaling, which controls vascular stability, and binding of angiopoietin 1 to the tyrosine kinase receptors on the endothelium of vascular cells leads to stabilizing the vasculature. So in healthy tissues, you can see on the left-hand side, there is a transmembrane tyrosine kinase protein activator, which usually is activated by angiopoietin 1 or inhibited by angiopoietin 2, which competitively acts against it. And along with that, we have transmembrane VEGF receptors, which is signaled by VEGF-A. However, in pathological conditions, there is something called an angiogenic switch in which elevated levels of angiotensin 2 and VEGF-A lead to vascular instability. So angiopoietin 1 is actually displaced from the tyrosine kinase receptors because it is competitively inhibited by angiopoietin 2, and that leads to inhibition of cell survival, leading to vascular instability. Alongside, we have VEGF-A, which is upregulated in pathological conditions on the VEGF receptors, which leads to promotion of angiogenesis, vascular permeability, and also leading to vascular instability. So the levels of angiopoietin 2 in several retinal diseases in vitro has been shown to be elevated. So this is a study which is showing the levels of angiopoietin 2 in AMD, in retinal vascular occlusions, in diabetic retinopathy, and in proliferative cases, where they're all increasing compared to the control levels. Looking at a healthy eye, the levels of angiopoietin 1 promoting vascular stability is usually more with low levels of with low levels of VEGF. But in neovascular AMD or diabetic retinopathy leading to diabetic macular edema, there is an upregulation of angiopoietin 2. This is led by hypoxia as well as signaling of VEGF-A. Diabetic retinopathy also follows a similar mechanism. This upregulation is known as an angiogenic switch, and angiopoietin 2 as well as VEGF leads to vascular leakage as well as neovascularization going forward. It also causes inflammation, which is sensitization of the vessels to the effect of cytokines, including VEGF-A, promotion of pericyte apoptosis, and reduction of endothelial barrier function. This also leads to the release of cytokines and infiltration of leukocyte macrophages into the inflamed tissue. So the summary of this process in cases of vascular instability is the dysregulation or the lack of homeostasis between angiopoietin 1, which is in resting state, and angiopoietin 2, which is in inflammatory stage. And this is the potentiating effect causing inflammatory signals going forward. This is where a new molecule, faricimab, being a single molecule which targets both angiopoietin 2 as well as VEGF-A together, which are the two drivers of choroidal and retinal vascular diseases. It is represented by a bispecific antibody where it binds to angiopoietin 2 and allows angiopoietin 1 to reoccupy the tyrosine kinase position on the endothelial cell, re-promoting vascular stability and reducing inflammation, while VEGF-A reduces vascular leakage and inhibits further neovascularization. The FC portion is a unique inhibited portion of the antibody, which leads to reduced systemic exposure and inflammatory potential. So together, faricimab is a molecule that binds to both angiopoietin 2, inhibiting it, as well as VEGF-A. So if you have a look at a blood vessel and its effect by angiopoietin 2 as well as angiopoietin 1, we can think of it as remodeling of a blood vessel with time, with increased levels of angiopoietin 1 in the presence of disease, where sometimes we can think of the vessel remodeling itself and regenerating its previous abilities to perform its functions in spite of pericyte loss due to diabetic retinopathy or neovascular AMD. As a molecule, 6 milligram of faricimab binds with VEGF-A as the same as 2 milligrams of ranibizumab. So the action of faricimab in its VEGF inhibiting capacities is equal to ranibizumab, 2 milligram, whereas faricimab is 3 times a larger molecule and its dose is 3 times higher. So what is the benefit of angiopoietin 2 inhibition in treatment-naive cases? This leads to early inhibition and better long-term disease control. Inhibiting angiopoietin 2 will lead to higher probability of vascular stabilization. In diabetic macular edema, the combined inhibition of VEGF as well as angiopoietin 2 leads to early control of inflammatory biomarkers, along with the inhibition leading to less formation of epiretinal membrane than using VEGF alone, as well as increased vascular reperfusion rates. So TENEA and LUCERNE will be discussed in detail. These were the phase 3 randomized trials for neovascular AMD. Alongside, faricimab was also tried in randomized trials as the YOSIMITY and the RHINE in diabetic macular edema as well. So moving forward in preparation for this talk, we know a lot from randomized trials, but what is the real world evidence of faricimab going forward? So this is just a PubMed search that I had done a couple of days back, and there were 23 results of real world evidences. The results are more or less promising, where intravitreal faricimab has shown to improve vision over a period. If I highlight this article in a personalized treatment interval after week 96 and a 12-weekly interval, as high as 78.1% patients, and at 16-weekly interval, as much as 62.3% patients in 10A and Lucerne had comparable visual acuity and better anatomical outcome. These are some other studies which show the real world evidence, and it is particularly promising because of its angiopoietin 2 inhibition. I've personally used faricimab for the past 4 or 5 months, and the results have also been quite promising. So globally, this drug has been used in as much as 4 million doses. There are some more higher trials that are the FAR Retina trial in DME and AMD, which are taking into consideration 25,000 patients, and the Voyager trial, which is currently considering 10,000 patients receiving the drug. I may be wrong, but the last time I checked, in India, more than 1,000 doses of this drug has already been administered. So taking this into consideration, thinking about other molecules that can be used in vascular diseases, we can think about doing now what the patient needs next. Thank you so much. I'll just stop my screen sharing.
So thank you, Dr. Anujit, for that wonderful talk and that insight on the newer drug. So now we'll have the panel discussion as we discuss the Journal Club article, because the two are very interconnected. So now I'll request our speaker, Dr. Meenal, to start sharing her screen and present the article. Over to you, Dr. Meenal. And all the best for your presentation.
Yes, ma'am. Very good evening to all. I would like to thank YOSI for this opportunity. And I hope my screen is on slideshow.
It's yet to come.
Yes, now it's...
Yeah, it's there. Yes. Please go ahead. Yeah.
So as discussed, in today's YOSI Journal Club presentation, we'll be discussing about this article, Retina and Lucerne 2-year results for the faricimab treat and extend dosing. Coming on to introduction, age-related macular degeneration is a leading cause of visual impairment and severe vision loss. It is a multifactorial disease with numerous processes and pathways involved in its pathogenesis. The intravitreal anti-VEGF therapy has been the current standard of care, but because there is a need for more durable therapies with reduced injection frequencies, thereby the pursuit for novel neovascular AMD targets other than just VEGF, such as the angiopoietin type 2 pathway as discussed by Dr. Anujit, which led to the discovery of this newer molecule, faricimab, which is the first and only bispecific antibody designed for intraocular use, and it binds and neutralizes both angiopoietin 2 and VEGF-A. So the purpose of this study was to evaluate the 2-year efficacy, durability, and safety of this newer molecule, faricimab. As we can see in this image, it has two arms. One inhibits the VEGF-A, and the other arm inhibits the angiopoietin 2 molecule. So this has been postulated that this dual inhibition lead to more durable efficacy via vascular stabilization, as very well discussed by Dr. Anujit sir. So the Retina and Lucerne trials were started as phase 3 trials of faricimab with dosing up to quarter 16 weekly as compared to aflibercept quarter 8 weekly. The initial 1-year non-inferiority primary endpoint was reached at year 1. And after that, there was a treat and extend personalized treatment interval regimen introduced starting from the year 2. And the 2-year outcomes I will be presenting in this presentation. Coming on to methodology, it was a randomized double-masked active comparator controlled phase 3 non-inferiority trial with participants including treatment-naive patients with neovascular AMD 50 years or older in age. So the key inclusion criteria are age more than equal to 50 with subfoveal CNVM, lesion not more than 9 disc areas on FA with active CNV confirmed on fluorescein angiography and a BCV of 78 to 24 ETDRS letters. The key exclusion criteria included CNV due to causes other than AMD, history of any other macular pathology unrelated to the AMD, any concurrent intraocular condition, or prior treatment for CNV. The randomization was done based on interactive voice or web-based response system using a stratified permitted block randomization method. So this in a nutshell tells us about the study design. So the initial fixed dosing interval was up to week 60 and at the primary endpoint was met wherein we found that faricimab was non-inferior to aflibercept, and after that treat and extend type of personalized treatment interval regime was followed for the faricimab group, whereas aflibercept was given at Q8 weekly. So the most important aspect for this study was the PTI dosing criteria. So in this dosing criteria, the interval of treatment was extended by 4 weeks if all of these criteria were met, that is a stable CST of more than equal to, with no increase more than equal to 50 microns in central subfield thickness, and no decrease of more than equal to 5 letters on BCV, and no new macular hemorrhage. If all of these criteria were met, then the treatment interval was extended. The treatment interval was reduced by 4 weeks if it was the contrary, like there is increase of more than 50 micron CST, decrease of more than 5 letter BCVA, and or presence of new macular hemorrhage would lead to a treatment interval reduction by 4 weeks. Whereas if none of these criteria were met, then the treatment interval was maintained. The key ocular assessments included best-corrected visual acuity assessment, intraocular pressure measurement, slit lamp biomicroscopy, dilated indirect ophthalmoscopy at each visit. Whereas apart from that, there were central reading centers that were getting images, ocular images for the fluorescein angiography, spectral domain OCT, and the fundus photography, which were evaluated by masked evaluators. The outcome measures included in the year 2 outcomes were change in BCVA from baseline, proportion of patients gaining BCVA, patients avoiding BCVA loss, patients with BCVA Snellen equivalent of 20/40 or better and 20/200 or worse, change in central subfield thickness from baseline, and proportion of patient faricimab treated patients receiving Q16 weekly, Q12 weekly, and 8 weekly dosing at the end of study. Also, the incidence and severity of ocular and non-ocular adverse events were reported. The statistical analysis, efficacy analysis were based on intention to treat population group by treatment arm assigned at randomization. Adjusted means for continuous endpoints were summarized using mixed model for repeated measures that assumed an unstructured covariant structure. Weighted proportions for binary endpoints were estimated using Cochrane mental Henser method. The safety was assessed through various descriptive summaries of the ocular and non-ocular adverse events and deaths and other based on other ocular assessments. The efficacy analysis were tested at a significance level of 0.0497. And all the confidence intervals were two-sided and at 95.03% level. So coming on to the result, starting with the functional outcome in this line diagram, we can see the adjusted mean BCVA change from baseline. For the TANAYA trial, it was plus 3.7 letters in the faricimab group and plus 3.3 letters in the aflibercept group. So the BCVA gain, change in BCVA from baseline were maintained throughout the study period. Same is the case with the Lucerne trial. The change in BCVA gain from baseline was maintained throughout the year 2. And this is the summary of the same in both the trials, TANAYA and Lucerne, and both the faricimab and aflibercept arms. We can see that there is a comparable gain in the visual acuity. Coming on to the structural outcome, this line diagram again explains reduction in the central subfield thickness from baseline. So it was observed that the baseline CST reductions were maintained and stable through year 2 in both the groups, although we can see that there is a slight sawtooth pattern in the aflibercept group, which suggests that there is recurrence of fluid as it is not that much durable as compared to faricimab, which has a stable plot. Similarly, in Lucerne also, we can very more easily see the sawtooth pattern of the aflibercept line diagram, which suggests that there is recurrence of fluid, whereas in the faricimab line diagram, we can see there is more of stabilization of the central subfield thickness. So this is again a summary of the same, wherein we can see, although there is comparable reduction in both the treatment arms, CST reduction is comparable, but the sawtooth pattern that we saw on the line diagram with the aflibercept arm suggests the recurrence of fluid more earlier in the aflibercept group. Coming on to durability outcomes. So the proportion of patients achieving 16-weekly dosing increased from approximately 45% at week 48 to 59% and 66.9% in Tenaya and Lucerne at week 112 respectively. Whereas cumulative percentage of patients receiving Q12 weekly and 16 weekly was 74.1% in the Tenaya group and 81.2% in the Lucerne group. So coming on to the safety outcomes, faricimab was well tolerated and comparable with aflibercept, with most of the ocular adverse events being mild or moderate. The proportion of patients with serious ocular events was low and comparable across both the study arms, although there was a numerically higher number of RP tears observed with the faricimab arm, but that was only in the initial rapid CST reduction phase. The incidence of intraocular inflammation IOI events was low. Coming on to discussion, the visual and anatomic improvements seen with faricimab at year 1 were maintained in the year 2, and more of the faricimab treated patients achieved an extended dosing interval with significantly fewer injections of faricimab as compared to aflibercept, as we have seen that in the whole of the study, there was a median 10 injections required for faricimab, whereas 15 number of injections were required for aflibercept. And if we talk about the year 2 data, there was the median number of 3 injections required for faricimab, whereas 6 injections were required for the aflibercept group. The treat and extend type of regimen that was included in this study provided the opportunity to adjust treatment intervals in a manner resembling clinical practice and to assess the durability of the faricimab. Thereby, these results definitely demonstrate the potential for dual angiopoietin 2 and VEGF-A inhibition, and it addresses the key unmet need for effective durable therapies that reduce the treatment burden without compromising efficacy of the molecule. Faricimab remained well tolerated throughout the study and with ocular adverse events comparable across the treatment arms. So the author's conclusion are the personalized faricimab dosing based on disease activity can maintain vision gain and control anatomic outcomes. The durability of treatment effect, with more of faricimab treated patients achieving and maintaining a 16-weekly dosing regimen, thereby requiring fewer injections. And these data support that dual angiopoietin and VEGF-A inhibition has a beneficial role for neovascular AMD patients. Coming on to the MARI assessment of this article, the study question was well defined, sample size was adequate with study inclusion and exclusion criteria very well defined, and being a multicentric study, it included patients from all the region. Although systemic risk factors were not taken into account and were not mentioned, study period was well defined, and further extended studies are required which are ongoing, like the Avenel X Then coming on to assignment, randomization was appropriately done. Follow-up was done every month, and injection either with sham or active component was done, which promotes masking. The treat and extend regimen in the trial used a comprehensive set of criteria, which was one of its kind, and wherein any signal suggesting suboptimal efficacy of the drug would result in reduction in treatment interval, whereas treatment extension was permitted only if the disease stability has been observed in both the anatomic and functional measures. Coming on to the assessment, the measurement of the outcomes like the best corrected visual acuity, clinical examination, color fundus photography, spectral luminosity, and fluorescein angiography all were appropriately masked. With more than 84% of approximately 84% of patients completing the study follow-up in both the arms. There is a appropriate statistical tests were applied on to get the study results. Our interpretation is as that the per protocol population consisted of all patients randomized who received at least one dose of treatment and did not have a major protocol violation. The safety valuable population also consisted of patients who received at least one injection of active drug, and the missing data were imputed implicitly by mixed model for repeated measures. The efficacy endpoints were analyzed using intention to treat population, and safety outcomes were summarized using safety valuable population. Thereby, the study results can be extrapolated to all the population considering the multicentric nature, and with detailed assessment of the ocular and non-ocular adverse events along with its relation to the treatment received has also been well summarized in the article. So my interpretation on the article is that it with adequate sample size and with more than 80% of the patients completing the treatment protocol, and a very well defined inclusion and exclusion criteria, the study can be extrapolated to all the to the global population. It gives a comprehensive set of criteria for determining the PTI, thereby avoiding the possibility of physician bias or variability, which is crucial for achieving analytical reproducibility of results. The study did not allow, although since the patients had to visit every month and they were given either a sham or active drug injection, thereby the study did not allow for a quality of life assessment of actual active treatment burden on patients. And also, as per the design of study, aflibercept was given as at fixed interval throughout the 2-year study period. Thereby, it was not a head-to-head durability assessment between the faricimab and aflibercept. So further extended studies are needed for long-term safety and efficacy outcomes of new molecule with dosing interval based on PTI for comparator control standard molecule as well. I thank you for the opportunity. That's all from my side.
Thank you, Dr. Meenal. That was really well presented. Extensive article presented very lucidly and very nicely. And I know that Dr. Ritika, who's your monthly mentor, also helped you a lot in preparing this presentation. So congratulations to both of you. Now moving on to the discussion of the article. So we'll have the comments by the research expert, Dr. Bhavik, later. We'll move on to Dr. Ruchir. I would like to invite Dr. Ruchir, our expert panel. So Dr. Ruchir is a young retina specialist working as a vitreoretina and uvea consultant at Tiwari Eye Center. Sorry for that. At Ghaziabad and Noida, and he's completed his medical schooling from Mamsi, New Delhi, followed by his post-graduation in ophthalmology and senior residency in the subspecialties of vitreoretina, uvea, and ROP at RP Center, AIMS. Later, he went on to Germany for an ICO fellowship in vitreoretina under Professor Peter Wiedmann in Leipzig University. His areas of interest include vitreoretinal surgery, retinal vascular disorders, age-related macular degeneration, uveitis, and pediatric vitreoretinal disorders, especially ROP. He's a keen researcher with a number of publications in peer-reviewed national and international journals to his name, and also serves as a reviewer for many index journals. So thank you, Dr. Ruchir, for joining us today, and over you for sharing the positive aspects of the article and your take on the article.
Yeah. Hello, Nupur. Hello, everyone. Very good evening. First of all, thank you, Meenal. It was a very nice presentation, very nicely presented. It's a very long topic, and you did a very fine job. So my take would be in two ways. First is if I'm looking at the publication as a researcher, it's a very well structured the protocol. And secondly, the most important point actually is that for me as a clinician also, that after a very long time, we are talking about some other target molecule, some other target area apart from VEGF, which may actually change the outlook of how we treat patients with retinal vascular disorders or neovascular disorders. So our search has been very long, and after a very long time, this is, I think, the first molecule with a bispecific antibody, which is actually yielding very good results. Before this, the only other molecule with a longer durability was brolucizumab, but then again, all of us know that it has its limitations as well. There are safety issues associated with it. So this fact opens up a lot of new areas of research, which should yield better molecules in the future. Second thing, as a clinician, all of us who are treating patients on a regular basis, we always had a problem with the financial burden to the patient of the treatment regimens. So I was very happy when I read about the PTI protocol, and the fact, something that Meenal did not highlight upon, was that there was very early stratification of the disease activity. So when we're talking about Q8, Q12 and Q16, we need to emphasize on the fact that this is as close to the real world as possible for a study. I've never seen a study done like this, where after the loading doses, they have actually divided the patients into different subsets based on the disease activity, which is what we all do. So, and eventually at the end of the day, after 1 year, when the patient has received a lot of injections, then we try to extend the interval. So this is what we learn as we go along practicing from our mistakes with our patients. But this is a very interesting approach now. So with brolucizumab also, all of us were talking about the decreased requirement for loading doses. And I think with faricimab, we're still talking about the loading doses, but then from there directly we are extending to say 8 or 12 or 16 weekly intervals, which is a big achievement. The last thing I would say is, because the molecule that we're talking about actually has an anti-inflammatory property and is very durable, it again opens up new avenues for treatment. For example, inflammatory cases, which for which anti-VEGF agents were of no use previously. So if you have a vasculitis case with active vasculitis, say with macular edema, it is possible that in the future, maybe one single agent will be able to do the job for both the problems of the disease. And second thing is something that I'm very much interested in is actually PDR. Like Protocol S, we were talking about 5 years back. All these longer duration molecules may have a role to play in that. So this opens up a lot of new opportunities for us. Thank you.
Thank you, Dr. Ruchir, for bringing out those positive aspects of the article so nicely, and also sharing your, take on the article. Now, I would like to invite our next panelist for the evening, Dr. Divakant Misra. He needs no introduction, very dynamic young ophthalmologist. He's the immediate past secretary of YOSI, the current vice president and the incoming president. He's currently the director at Suwanjoti Eye Hospital, Aliganj, Lucknow, and he heads the retina services there. So over to you, Dr. Divakant, for sharing the negative aspects of the article and your personal take on the article.
Thank you so much, Dr. Nupur. Am I audible?
Yes, Dr. Devakant, you are.
Perfect. So congratulations to the presenter, Dr. Meenal, for such a lucid presentation. And as Dr. Ruchir has pointed out, it's a wonderful piece of research that has really brought out the positives of this wonderful drug. I've personally used the drug and have some great results. Uh, there's certain really small points that we can also discuss about the negative aspects. All of we see while conducting such big results, there are always some points that we can think about the negativities that are there. So I feel that the study design, there were certain constraints, as it has also been mentioned in the article in the limitations aspect, that the patient required monthly injections, either sham or the real injection. So we did not know, could not assess the actual burden of an active treatment on the quality of the patient's life. The other point was that at the end, it is a non-inferiority design. So we really do not have a head-on-head trial, head-on-head comparison with the drug. But the major aspect that they wanted to focus on to prove the non-inferiority of it. So probably we'll have more studies where we'll have head-on-head comparison of both the drugs. The other thing was that there were certain protocol deviations that were noted, uh, probably due to COVID, but that has been dealt with lightly in the limitation aspect. So what I feel is that this was conducted through the pandemic time, so I'm sure it would have had some big impacts on how the proper flow of the research would have been done, the trial. So that has not been highlighted really well. There were certain concerns of safety that was pointed out in terms of having more RP tears that were observed in the faricimab group. So it would have been interesting for us to know what was the cause for a higher number of RP tears in these cases. Uh, Apart from that, I feel there were some discrepancies in the baseline characteristics as well. There was the BCVA in this group was higher when we compare it to other historical trials. So that might affect the its comparability to the past research that might be there. Again, at the end, there have been claims, durability claims, which we have to study on our population and then compare it to the real world data. And that validation would be, will come soon when we have more injections throughout India and on our own demographics. So it gives us very important insights in terms of the efficacy and the safety of faricimab. But these small negative aspects we should also think about while, reading these literature. Yeah. Thank you.
Thank you, Dr. Devakant, for bringing out those negative aspects of the article. And moving on further to our next expert panel, we have on board, we have Dr. Kartikeya Singh. So Dr. Kartikeya is a highly skilled ophthalmologist who has done his training from RIO BGMC Ahmedabad and is advanced qualifications including FAPT, FVRS, and FICO. So he specializes in the management of medical and surgical vitreoretinal diseases, and he has considerable expertise in macular surgery and retinopathy of prematurity. So with over 5,000 complex vitreoretina surgeries and extensive experience in cataract and refractive surgeries, he currently serves as a phaco and vitreoretina surgeon at ASGI Hospitals, Varanasi. He performs around 100 retina surgeries monthly and has initiated long-term training programs for vitreoretina fellows and international observers. So welcome, Dr. Kartikeya. Thank you for joining us today. And I invite you to share your take on the article. Over to you, Dr. Kartikeya. Hi.
Thank you, Dr. Nupur, for such a nice introduction. And it was really good to see all the, and as Dr. Ruchir was also saying, it's very good to see a new molecule after so long, and which we can use for multiple ways. So I'll not take much time on what to share, but I'll just share a few specific points which actually is asked when something new comes up. So I'll share my screen of few slides. My screen seen?
It's still in
No, we
slide
can
show.
just see. Yeah, yeah.
Yeah, now it's.
Yes.
Can you see my screen?
No, we cannot see the full screen.
Hello?
Yeah, Dr.
you make it
Karthik,
full
it's not on
screen?
full screen.
Cannot see the full screen?
No.
It's not on full screen.
No, it's not on full screen for us.
Can you see?
Do you want to
Okay.
unshare and share it
1
again?
minute.
Yeah, now it's on
Yeah,
full.
yeah. Now it's on full screen.
Now?
Yes.
Okay. All right. So I'll just quickly go through what is my take. So I started giving this injection about a month ago, around let's say 5 weeks. So I'll just say it's a bispecific anti molecule which is working in ANG2 and VEGF-A, as we all know. Currently, it is indicated only for neovascular AMD and diabetic macular edema. Yes, there are few research articles there are few studies which are ongoing for RVO as well, and it will very soon come out and it will be published that way as well. So I'll not talk on these things because it has been already spoke on. So what is a special consideration? So anything which comes new, a lot of people have questions about it, like when to give, what are the conditions where you cannot give the drug, like is there any certain indication where you cannot actually give the drug? So yes, the first and foremost is a pediatric patient, because most of the times we get this question: can we inject this drug in pediatric patients? Can we inject this drug in ROP? So I don't know whether we can do it or not, but still the safety and efficacy has not been established. And these are the patients where you should not inject the drug until and unless it has been approved by FDA, approved by DGCI, everything. So this is the first thing which I take from the article, and pediatric is still it's a no. So when the patient has a kidney disease, no dose adjustment is required for the drug, and it has been proven and it has been given by the Ross group as well. In the hepatic impairment also, there is no special consideration which has been required, and you can inject the drug if the patient has a hepatic failure. No special modification is required for any age group like elderly or gender or race. For all those things also, there is no consideration at all. So adverse events are very much common to other anti-VEGF which we are giving, but there are a few specific things which was mentioned in the article, in the detailed article, which I would like to say. So cataract progression was slightly more than other anti-VEGF agent. It was 12%. And maybe probably because of the duration, it stays in the anterior hyaloid phase. I'm not very sure about it, but still, it's my speculation about the drug that it could be the cause why it is causing cataract slightly more than others. IOI is very less frequent, as Dr. Ruchir and even Meenal was saying in the presentation, that it is somewhat anti-inflammatory as well. So IOI, intraocular inflammation, is not that frequent that it is noted by previous molecule, which actually brought out that intraocular inflammation can actually happen with anti-VEGF agents. So it is less frequent. SCH, subconjunctival hemorrhage, and PVD is slightly more again, because if somebody has injected a drug, the drug is slightly viscous, and it takes a little longer to inject than the normal anti-VEGF. Anti-VEGF is usually very fluidic, but this is slightly viscous. So if you take and inject, sometimes you stay at the conjunctiva slightly more than it's just a very variable thing to note on. IOP spike, again, immediate IOP spike is there because maybe again because of the viscosity of the fluid, it is staying there and it's not spreading very well to the liquefied vitreous, and that is why there can be a IOP spike. And I have seen in my almost 30 cases, I have seen 4-5 for a week there will be some IOP spike. Floaters, again, as it is compressing, being a very viscous fluid, it is compressing the vitreous slightly more. So floater could be more, but still I'm not very sure whether to want to comment on this, but I feel that there could be more floaters with the injection, repeated injection in these cases. So others, as I told, it is very common to all other anti-VEGFs, not very particular like ENDOF and all those things. It is all dependent on the contamination and everything else. So I'm not going to discuss on those aspects. So post-marketing surveillance, rare cases of retinal vasculitis and retinal occlusive vasculitis has been actually reported, and but the reported incidence was not that much, and I will not be I'll not be talking much on that because again, it is yet not a very significant issue with the drug. So let's not go in details of that. And all the cases which were reported were very well controlled with the conservative management only. So the reported incidences were actually lower than ranibizumab and aflibercept, probably due to the ANG2 inhibition, which has a potential anti-inflammatory action. So my clinical experience is of 13 injections, as I told. I am not including any cases here because I don't want to make a precluded judgment on how it is acting in my patients, because it is very early to say how the drug is acting. Definitely, there is not a wow effect which we saw with brolucizumab, because there was something else. It used to do something else, but this drug is doing things slightly. I have seen 2 cases. The PED is flattening, but after second injection, all other cases, it is giving a very slow effect on the SRF and IRF. Maybe that is good. That is very good for us. It is not drying up. The drying effect is not very fast and rapid to cause derange effect like RP, RIP, and all those things. So this injection looks very promising. Let's wait for another 2-3 months so that in my experience also I can share more insights on this. That's all from my side. Thank you.
Thank you, Dr. Karthike, for so wonderfully sharing your take on the article and also sharing your clinical experience with us so candidly. So moving on, we'll have a panel discussion towards the end. We'll first hear from all the panelists. And now I would like to invite our next expert panel on board, Dr. Rohit Modi, who's also a very dear friend and, as I mentioned, a very key member of the Journal Club. In fact, Dr. Rohit is one of the persons who's been very helpful, in formatting with the MARI format. He's been there all the time, whenever we've asked him to help us with the MARI format for any article. So Dr. Rohit Modi is a fellowship-trained vitreoretina and uveitis specialist with a special interest in biostatistics. And he's a director of Centra Clinic in Hospital Mumbai. He's a LVP-trained VR surgeon. So over to you, Dr. Rohit, for sharing the recent advances on the topic.
Thanks, Nupur, for making me a part of the team. So, when we look at the recent advances in the treatment of AMD, the exciting thing which we see with faricimab is, the mechanism of action of the drug is multifaceted, and it is both anti-VEGF and as well as ANG2 inhibitor. Basically, ANG2 destabilizes the existing vasculature, making it more responsive to VEGF signals. So a combined therapy increases the effectiveness. And there are multiple other drugs which are being in different phases of trial for a similar mechanism of action. Along with that, there is also a port delivery system with ranibizumab, which has been available in certain countries. It's an ocular implant that continuously delivers ranibizumab into the vitreous humor. It consists of a drug reservoir, a release control element, and ancillary devices for filling, implantation, refill exchange, and explantation. And ranibizumab is released through the implant through passive diffusion, and which is tailored to the drug's molecular characteristics. In fact, in clinical trials, including the phase 2 ladder and phase 3 archway trials, they have demonstrated that PDS delivers ranibizumab effectively, maintaining the drug therapeutic levels for at least 6 months. And that is really exciting because it reduces the number of re-injections. And it was found to be clinically injections. Apart from the PDS, we are also looking at advances in the gene therapy for wet AMD, particularly focused on therapies that prompt the eye to produce anti-VEGF proteins. 2 promising therapies, RGX-314 and ADVM-022, use non-integrating AAV vectors to deliver genetic material that helps the eye to create these proteins, potentially reducing or eliminating the need for frequent injections. Early trials have shown the reduction of injections as high as from 60% to 85%, and it has shown promising results both in wet and dry AMD. Obviously, there are ongoing research aiming to refine these delivery methods and improve outcomes. Now, this can actually revolutionize the AMD treatment. Apart from that, when we look at the future, there is a possibility with the newer advances in the genetics, we may have personalized medicines. As it was discussed before, some patients may require 2 monthly, some patients may require 3 monthly, and some patients may require 4 monthly injections. Along with this, artificial intelligence and artificial advanced imaging technologies are improving the diagnosis, monitoring, and treatment planning for wet AMD. Thank you.
Thank you, Dr. Rohit, for sharing the recent advances and the possibilities for the future that await. And now I would like to invite our research expert for the evening, Dr. Bhavik. So, Dr. Bhavik, Dr. Bhavik has completed his primary education for TN Medical College, Mumbai. So incidentally, Dr. Bhavik was also my junior during MBBS, and he has done his DNB, followed by his clinical fellowship in Vitro Retina and uveitis from LV Prasad Eye Institute. So he's a clinician with keen interest in research and academics, and has to his credit several index publications in international peer-reviewed journals. He has presented multiple papers and poster presentations at national and international levels, and has won several national and international awards. Dr. Bhavik Panchal is a passionate teacher and is actively involved in the resident and fellow training. In future, he aims to take ophthalmic digital education to greater heights. And his clinical area of interest are pediatric retina, retinopathy of prematurity, infectious and non-infectious uveitis, and managing complex retinal attachments. So over to you, Dr. Bhavik, for giving the statistical critique of the article.
Yeah, thank you first of all, YOSI and Dr. Nupur for this warm invitation, and Dr. Meenal for lucidly presenting, and to all the speakers who spoke before me. The critical aspect of for this, actually, this is a 2-year study. So the first year study already, which was evaluated and I think presented in a different forum. So rather than critically assessing the article, I was thinking of, because there are a lot of new terms in this, since this is a 2-year study. Can you all see my presentation?
Yes, sir.
Yes,
You can
Dr. Bhavik. Yeah.
Yes.
Just need to put it on full screen.
Yeah. So the thought here was that let us go through a lot of new terms which were discussed in this article. One aspect here was about clinical versus statistical significance, which Dr. Karthike also brought in as well, and about real world experience as well, right? I think what Anujit had presented in the earlier part as well. But before this, let us start from the basic. Like the introduction itself, the title says that phase 3 trial, right? This is a non-inferiority trial, where people are mentioning about non-inferiority as well. So the phase 3 trial is the final stage of testing a new drug or treatment before it can be used for widespread audience or doctors everywhere. Just 1 second. Yeah. So it involves hundreds of thousands of patients. On average, 3,000 patients is what is required for any drug. It confirms the drug's efficacy and the safety aspect of it, right? And also it gathers data for further drug labeling and prepares for the phase 4 once it is approved in the phase 3. The next here, what we understand is the efficacy analysis. So who all are participants here? All patients are included, regardless of whether they completed the study or switched treatments. Okay, so the parameters that are looked here is continuous data, like vision, for example, yes, no data, whether the soft field thickness has reduced or not, yes or no is something. Patient has come to the clinic or not, right? And here in this particular article, since COVID was a part of it, patients who got sick with COVID-19 were handled differently than those who got sick with other illnesses. The next part for any phase 2 study is the safety analysis. So here all patients are included, at least who received 1 dose of the treatment, right? So you look at the side effects, that's other problems related to the eyes or not related to the drug as well, right? Again, this is all standardized format which are available. When you look at non-inferiority trial, it aims to demonstrate the new treatment is not significantly worse than an already established treatment. Here we are comparing faricimab, a new drug, versus aflibercept, which is an already established treatment. That is why it is a non-inferiority trial. Okay, a non-inferiority trial focuses on showing the new treatment is not substantially worse, whereas a superiority trial will always aim to prove that a new drug is better than the existing one. So this is the difference. Always difficult to prove that something is better when the margins are 4 letters, 5 letter gain, right? So the next point here, which was brought about, was intention to treat population. Okay, again, why this came in? Because of COVID, patients were lost as well. So this refers to all patients who were originally assigned to a treatment group, regardless they completed treatment or not. Again, this actually mimics the real world scenario. It's not like our patients are going to follow monthly to monthly. We're going to get patients who are going to be off for 4 months. I went to the US. I went to my for a wedding. I was not well. I was undergoing dialysis. So they may get lost to follow up, right? So this is where entire group has to be analyzed, and this gives a more realistic picture of the treatment's effectiveness. Other point here was missing data, since lots of patients could not come for follow-up, right? So here they have used a method called as imputation to estimate missing values based on the whatever available data are there. And so if you look at it, they have written that mean advanced or mean adjusted BCVA, mean adjusted thickness. This is the reason why, because of the imputation method. Okay, mixed model for repeated measures. Again, this term comes multiple times in both the first paper and the second paper. Again, this is to analyze data that is collected over time. Okay, this is for the same person that are likely to be related in the same data point, which is for that individual. Okay, the next big term which comes here is CMH method, that is Cochrane Mental Hensel method. Again, though the name is big, it is quite commonly used, especially for larger groups, to compare proportions between the groups. Right. So it is to assess the relationship between two categorical variables while controlling the effects of the third categorical variable. Okay. So let's not go into details of it. This beyond this class. It is used in observational studies where random assignment to treatment groups is not possible. Okay. Especially important when there is a confounding variable. Right. And the final thing here is hypothetical strategy and treatment policy strategy. So this is there in multiple multi-center trials, especially during the COVID period when the patients could not follow up. And once the patient is lost to follow up, when the majority of the patients are lost to follow up, say beyond 10%, maximum 85% is something that you can accept. But if it goes beyond that, so 15% of the patients are lost to follow up is fine. But if it goes beyond that, the study results may not be ideal. So much of money being put into it, effort being put into it, you do not expect. So you have to come up with something different. So this hypothetical strategy assumes that the patient's condition worsened after the event. It may or may not have worsened, but you always look at the worst case scenario. While the treatment policy strategy uses all the available data regardless of the event. That means a patient may have visited third visit, fourth visit, and they have come directly at the ninth visit. So you are not going to discard the data beyond fourth visit. Earlier, you will be discarding the data only till it is available, and the last visit you will be taking. In between, you may discard, but that was not done for this particular study. So this is how it was different compared to other studies, and a lot of things we get to know from here. Just the last slide on clinical significance. What's the statistical significance? The statistical significance basically focuses on the probability that the observed results occurred by chance. Okay, and it is determined by p-value, whereas a clinical significance is relates to the practical importance of the findings. It depends on the patients as well. How much improvement did the patient feel? Okay, we say it was 4 letter gain, 3.6 letter gain. If you ask the patient, he's like, I don't see any difference. Okay, so that is where an expert judgment and patient input is required. So sometimes the statistical significance may not be much, but the patient feels dramatic improvement. This is where what Dr. Karthikeya Singh was saying, right? That or the PED did not flatten much or it recurred and all. But I think it's also important to take the patient's perspective into consideration before we give a verdict as well. In short, statistical significance is a necessary but not sufficient condition for clinical significance. whereas clinical significance is often assessed using effect sizes, confidence intervals, and patient-reported outcomes. So both are crucial, and it has to be a balanced form. Thank you for your patient listening. I know it was a longer monologue.
Thank you, Dr. Bhavik, for giving those, bringing out those statistical nuggets. And moving on further, we have Dr. Ritika, who's the monthly, sorry for that background disturbance. So we have Dr. Ritika as the monthly mentor. So 1 second. So Dr. Ritika has done her MS from Jaipur, SMS Jaipur. She is done a Virtue Retina Fellowship from the prestigious Samhita Netralaya, Chennai, and she holds a special interest in macular surgeries. So she's presented in various national and international conferences, and she's recently won the YOSI First Prize for challenging medical cases. So over to you, Dr. Ritika, for summarizing the article and the discussion so far before we move on to the clinical discussion.
Thank you, Nupur ma'am. And I would like to thank Team YOSI for making me a part of this journal club. I'll just quickly share my screen. Is my screen visible?
Yes, Dr. Ritika, you can press full screen.
Yeah. 1 second. Yeah. So first and foremost, I would like to congratulate Dr. Meenal for putting up an amazing slideshow. And as a mentor, I really didn't have to do anything apart from just, having to do a few changes. Congratulations, Dr. Meenal. And then I will just go on with my presentation. So we all know that ARMD is a very frustrating disease for the clinician and for the patient. There is a lot of treatment burden, there is a financial burden, and then even after all this, there is eventual poor visual outcome. So, slides are not
you can just press the arrow down, the arrow, right-hand side arrow button on your left side.
Lower left-hand side arrow.
Yeah. Yes.
Oh, yeah. So as Dr. Ruchir also said, for so long, we've been only discussing about anti-VEGF as a molecule and different molecule. And it is after so long that we have another molecule, which is faricimab, which can act on 2 different pathways to give the patient a better visual outcome, and also to reduce the burden, the financial burden for them, and also number of visits to the hospital. So sure, this article tells us that the BCVA was comparable and the CST reduction was comparable to aflibercept. But the major thing is, in Tenaya and Lucerne, what it shows is 74.1% in Tenaya and 81.2% in Lucerne. Patients were able to achieve a extended dosing regimen. So that is very important as far as the clinician and the patient is concerned, that the number of visits to the hospital also decrease along with the visual outcome. So this is that is why the molecule looks good, and maybe in the future we still have to have long-term studies, and maybe in the future it becomes one of the molecule where it is given in all these indications. But yeah, this extended dosing regimen is good that we can take away from this article. There were a few limitations, like aflibercept was given at fixed intervals, but we've seen even aflibercept can be given for extended dosing. We have papers and research on that. And secondly, the quality of life wasn't assessed, because even for the sham, for the sake of randomization, of course, people had to come at every 4 weekly visits. And for real world scenario, we definitely need more long-term studies as to how this molecule is helping visually and in extended dosing regimen. Coming to journal clubs, as in why fellows and PG students should do journal club, is we get a little one-on-one mentorship, which is helpful for them. It also increases their confidence before presenting in conferences and other award sessions. And I would like to believe that all of us are a little friendly and interactive. So we provide them an interface so that they can come and ask us different questions. And there is also scientific discussion and statistical discussion of the journal club, which we are not usually told in our residency. So that is what fellows and residents can take away from these journal clubs. Thank you.
Thank you, Dr. Ritika, for being such a wonderful monthly mentor and summarizing the article and why you selected this article. Thank you so much. I hand over the podium to Dr. Anujit now to take over the discussion. Since you presented that angiopoietin inhibition, it's not my specialty. So over to you, Dr. Anujit.
Right. Thank you so much, Nupur ma'am, and excellent job, Dr. Meenal. So, a couple of things in faricimab, if we can just discuss and get them out of the way. So, I would like to ask all the panelists on their experience with faricimab. So, Dr. Karthike pointed out very clearly that faricimab does not have a wow effect like brolucizumab, especially for those who have converted to brolucizumab early when it came out. I think they have an evidence of using the drug for almost 5, 6, 7 years. So, Dr. Karthike, do you load your patients? Are you loading all patients with 4 doses of faricimab? I would like a comment from all the panelists. So I'll just
Hi.
go one by one
Hi,
as I.
Dr. Anil. Yeah, I'm actually doing that. I'm not doing 4 as it was recommended for 4, but I'm actually asking them 3 only, because what we are seeing that we have been already giving the promise of 3 loading dose with other anti-VEGFs. So if we say 4, the patient tend to lose the touch with you, and he says that why, if the drug is so good and the drug is so advanced, then why do we need 4? I'm telling that you might need 2 more, and which will be given like as they have a plan also for giving the last 2 doses for free of cost. Only injection cost will be given, but I'm telling that only 3 will be required for now. So this is what I am telling all my patients for now, and that's how they are getting converted also maybe.
Right. So are you have you reached three doses plus another dose for any of your patients?
No, not yet. I've given only 2 for only 2 patients. Total I've given only 13 injections so far. I started very late because there were some incidents in my clinic with brolucizumab, which I thought that, okay, let's wait for some time. Let's watch the drug properly, and then only I'll start giving it. So I've started probably maybe in 3-4 months, I'll have many patients.
Right. So, same question I'll go to Dr. Rohit Modi as well. What has been your experience with faricimab, and are you loading all your patients with the drug?
In my practice, Anujit, I have not started use of the drug because right now my practice, I focus a lot on aflibercept and brolucizumab. So faricimab, I have not started yet.
So I have an interesting question for you then, sir. So
Yeah,
for considering your first patient, the drug is not costly, it is coming to you without any cost. Are you looking forward to switching your ranibizumab or your aflibercept patients, or would you rather shift your ranibizumab first to either aflibercept or brolucizumab and then go for faricimab, or would you go for a direct switch?
So obviously, if the cost is on the lower side, then I would shift to faricimab. The challenge is that, when I'm looking at wet AMD, I'm looking at at least 3 to 4 years of therapy. So there are a lot of patients of mine who are on Zaltrap and they have received, 15, 16 or 17 injections over the last 3, 4 years. So I'm looking at that kind of a follow-up. So the cost becomes a constraint, and a lot of patients have an insurance of around 5 to 10 lakhs, what I see in my own practice. So the insurance coverage is 10% yearly of the total amount which is covered. The sublimit is 10%. So then, the sublimit doesn't even cover the first shot of faricimab. So that's one of the reasons why I have not still started yet in my practice.
Right. Thank you, sir. Dr. Bhavik, your take on loading the drug. Have you loaded the drug in your experience?
No, so I use a different strategy in terms of the PTI, which is there from beginning itself. So I have been using faricimab for the past 3 months now, 4 months rather, and use for both treatment naive wet AMD, treatment naive DME, and for patients who have chronic DME, refractory DME, and for patients who were on Avastin or bevacizumab or ranibizumab and switched over to faricimab as well. So I don't switch over from aflibercept to faricimab because aflibercept also the patient support program is ongoing and the patients are doing well. So there's no point shifting patients who are already doing well to a new drug, right? Especially patients who are with PCV have received multiple injections. Those are the patients who are informed about this new drug. So the patients are also educated. Most of them who they come to me. One of the patient had asked me that why don't I try the drug in his case. So I was also surprised about it. So I don't say as a loading dose. What I do is I explain them. It's the patient's choice. Once they select it, after a month, I get them back for the scan, and I repeat the in a treatment naive patient. I repeat it at 6 weeks, the second dose. The third dose can be at 2 months, 2.5 months.
I think we lost Sir. So I'll get back to him on his points. And in the meantime, I'd move to Dr. Ritika. Can you share your experience?
So I haven't started at my center as of now.
So
Just
So
waiting.
would you shift your previously ranibizumab recalcitrant cases, or would you shift a patient who's having an AMD and already on brolucizumab and having a recurrence, and would you counsel the patient for this newer drug and 4 doses one after the other? Would you do that, or are you looking for your first treatment naive to start off with?
No, I would definitely like to put my already treated patients and recalcitrant patients on this new molecule because most of them get aware of this molecule actually, and everybody comes after reading Google and everything. So I definitely will tell them, inform them about the new drug which is there in the market. And for me, also, I would like to change them. It might just help them using two pathways. I'm not really sure about the treatment naive, but definitely the recalcitrant one I would like to start.
Right.
Yeah. Can I continue? Sorry, I think my network went away in between.
Awesome. Yes, yes.
Yeah, so I was talking about treatment naive versus recalcitrant. So in recalcitrant ones, I say I have a more than an average response, rather a very good response from my patients, unlike what Karthike was not that happy with his patients. Again, it's too short, maybe just 10 or 11 patients what I have. Uh, Patients with DME who has received multiple Ozurdex, anti-VEGFs, and is like fantastic response, just the first drug. I know recurrence is going to happen, and for DME, you need systemic control and all those aspects come into play here. For AMD, for the treatment naive as well, the response in the month itself is good compared to what we have seen with ranibizumab. And with aflibercept, I think it's comparable as of now. But to start on directly on treatment naive or not, I think it's a safe drug. We had issues with brolucizumab where even I had a patient who had vasculitis and inflammation. So I was a little skeptical about continuing this, starting this drug. But then if you look at others' experience, your peers and your colleagues, you take a feedback from them, and you realize that okay, it's a good drug. But the patient can benefit. Patient has insurance. Why not try? And if they can do well, that was the idea.
So two follow-up questions for you, sir. So are you seeing a sort of wow effect, a proper drying in these cases? Because Dr. Karthike mentioned very clearly that he's not seeing a very good drying effect as he would have seen in brolucizumab.
In my refractory DME patients, yes, definitely, I say a very good wow effect is there.
Right.
Refractory wet AMD, okay, not that great, I will say, as in like again too early to say just 2 injections. But treatment naive wet AMD, excellent response. Again, just 2 cases, it's a small sample size, which normally I prefer bevacizumab or ranizumab. But compared to them, this had a wonderful response. And now the advantage is that patient doesn't have to come monthly. So
Right.
that way patient also is happy. Other
Right.
point here is that I'll never commit to a patient that you'll give 3 injections, 4 injections. I think it's because you never know. Sometimes I Rohit mentioned 15 injections, 20 injections. So even I have patients who are taking 25, 30 injections as well. So it's very difficult to, if you give a number and if it exceeds, patient doesn't have a good experience then. So you should try to be very optimistic at the same time and say that, okay, this is what in a study was done and patient required 4 injections in a year. In the next subsequent year, second year, they required 2 injections, 3 injections. That is a good way to put up.
Have any of your patients been treatment naive DME?
Yes, one patient is of treatment AME and 2 patients of treatment naive wet AMD.
Okay, okay. Dr. Ruchir, sir, your take on your experience with the drug if you've used it.
Yeah, hi Anujit. So I have a little different. I think my version would be similar to Dr. Karthikeya's version simply because I think I was very early in switching to brolucizumab. So more than 95% of my wet AMD patients are treated with brolucizumab. And I've used around, I think I've used more than 500 vials of brolucizumab till now in the last 4 years. Very good experience. Luckily, no reactions as of now. It works really well in DME. So when Dr. Karthikeya says that there is no wow factor, I think it is simply because he's comparing it with brolucizumab and no other drug. So for me, when faricimab came out, the only option was that when a treatment naive patient comes to me, I give that patient an option that now you have 2 very good drugs. One will require loading, the second may not require loading. And anyways, I don't inject brolucizumab less than 2 months. So there was one particular patient who received 15 injections, 6 weekly brolucizumab, and she had tried everything else. That was the first patient that I wanted to switch to faricimab. So I have, I think, around 6 to 7 patients who are receiving 7 to 8 weekly brolucizumab who have shifted to faricimab. The results are still awaited. Most of my newer patients, I just give them the option, and if they choose, if they get the patient support program, for example, as Dr. Modi said, the support program is actually there for patients who have an insurance of less than 10 lakhs. So there are a lot of caveats also in the support program. So we need to look at it. But I think with the data that we have coming up now, this drug should do well. So brolucizumab is still the go-to drug for me for all my cases. I have not had a single case where the drug has not worked for DME or wet AMD. And faricimab is a very good second option or as a first option if the patient chooses so. So that is how I like to treat my patients.
So the patients that you have kept on brolucizumab and shifted, are you loading those patients, sir?
No.
Okay.
So again, the point is that there are a very few, 4 or 5 patients are there, and I only have injected the injection once. I think I used 14 or 15. So I think within 3-4 months, we'll get to know what our Indian data is like.
Would you go to say that faricimab is a drug of patience? Because I think we've become used to getting a lot of dry maculas after brolucizumab came in, and now we have to shift back to waiting for a cumulative action for the drug.
So there was this a discussion happening somewhere else where it was shown that you do require loading doses with faricimab. But then even with my own patients with brolucizumab, I have a lot of cases where I used to call the patients for 2 weekly OCTs. So there is documented evidence that there is still the drug acting between 4 to 6 to 8 to 10 weeks. So if I call the patient directly at 8 weeks, I may miss the situation. I may not be gauging the situation right, that there is some fluid, but by 10 weeks, the fluid may still go away. So I'm presuming that faricimab may have an action like that, that if you want to inject it 4 weeks, that the response is not as per your expectations, wait for 2 more weeks. These newer drugs are actually supposed to work better. They should work better. And I still don't understand why we can say that a 16 weekly interval is good, but 4 loading doses are still required. I cannot answer that. So I don't know. I mean, with time, like brolucizumab, we have all shifted to PRN from beginning. Maybe with faricimab also, we will get more data supporting the hypothesis that these injections work a little slower, but they work longer.
Because I feel the angiopoietin action takes at least 3 loading doses for it to actually show its benefit, even though we speak about it as if it happens immediately. Do you feel this, Bhavik sir, since you and Kartikeya sir? Because this is something which is the difference between actually speaking about it and experiencing it when you are injecting the drug.
Yeah,
We don't,
it,
we
yeah.
don't see the angiopoietin action immediately.
Yeah, yeah. See, if you, so the first thing that I asked the company guy was when he was describing the molecule was, I told him, that it is like 3 molecules of bevacizumab. You have
Exactly.
the dose of bevacizumab and you've added ANG2. You've not done anything else. Instead of 1.25 mg of bevacizumab, you have now 4 times bevacizumab and you have another molecule. So if I double the dose of Eylea, or if I double the dose of ranibizumab, or if I triple the dose of aflibercept, maybe we'll get a better response. But then the molecule seems a little different. And I think with our experience with time only, we'll be able to tell whether it is as good as brolucizumab, because I have patients who have not required brolucizumab for more than a year. They do have recurrences. Even after a year, the patients require follow-up, but the drug works really well.
Absolutely, sir. Even I echo your thoughts that there are, in spite of all the negative press that brolucizumab gets because of its adverse effects in the patients that it works, these patients are almost 12 months, 14 months, 16 months, sometimes even 18 months drug-free. So it does have effect. Bhavik sir, your take on that, as well as is Rohit sir still there with us? Bhavik sir, your take on brolucizumab in this respect?
No, agreed. Again, brolucizumab also is a wonderful drug. I feel any drug that gives us a larger treatment interval, right? Treatment-free interval is definitely an advantage from the patient's perspective, from the doctor's perspective as well. Lesser number of follow-up to the patients for the patients, right? And it helps economically to a significant extent to the patients. And what you mentioned, brolucizumab, the drying effect is fantastic. Okay, and I'm not trying to compare the two drugs here in terms of, I feel that there will be takers for both the drugs. Brolucizumab I'm sure, like, I don't know if you all are aware of this, in CSCR also people have started giving. So it has a larger, I feel, role, not just related to DMA and wet AMD. And I think we'll wait for some more studies and some more trials. So I think both the molecules are good.
Right. So thank you so much. Thank you to the entire panel for sharing not only your experience, but also your thought process behind this drug, your thought process behind finally, after 15 years, having a new way of targeting retinal vascular diseases. I think this was a very interesting discussion to know for the young ophthalmologists who are listening in on what they should go for, what people who are using the drug are doing right now, their initial and their semi-initial experience, as well as those who are planning on using the drug, what should be their standpoint. I think angiopoietin 2 is a promising molecule. I personally call it the drug of patience, because in the world of fast food and fast drying of macula, I think we've lost the idea of waiting for disease progression to take its natural course. So that's my final take on it. With that, I'll hand it over to Nupur ma'am once again.
Thank you, Dr. Anujit, for nicely curating this clinical discussion. So with this, we come to the end of our journal club session. And again, I would like to, with this, we'll start with the presentation of the certificate. So our first presentation of certificate to Dr. Anujit for giving that wonderful talk on angiopoietin 2. And also, let me tell you that this, session was actually thought of by Dr. Anujit that, let's have it in this format, discuss this new drug, this is something which is very in, and also have this clinical experience. So thank you, Dr. Anujit, for your wonderful contribution and for your wonderful talk. Our next certificate of presentation to Dr. Meenal, who presented the article so well. Thank you, Dr. Meenal, for, and congratulations to you. Then Dr. Bhavik, thank you for being our research expert and giving those nuggets on the biostatistics and the newer terms that were there in the article for the YOS to understand. Dr. Ruchir, for discussing your clinical experience so candidly, and also for bringing out the positive aspects of the article. Certificate of appreciation for Dr. Devakant for bringing out the negative aspects of the article. and for joining us today, and Dr. Karthike for joining us today, and also talking about his clinical experience and take on the article. Dr. Rohit, as always, for being an integral part of Journal Club, and for this session, for discussing the recent advances on the topic. And with this, we come to the end of this. So this was the last Journal Club session of the team 2022-2024. It's a very nostalgic moment for me. It's as you say that all good things come to an end, but no, it's not like that. That good things will continue, and with a better version. With this, the new team will take on board, which will be headed by Dr. Prasanna. So over to you, Dr. Prasanna. I welcome you to take over and share your thoughts. I'm sure that you are you will come up with some wonderful ideas. Dr. Prasanna, would you want to speak a few words?
Ma'am, thank you, and also thank you to the YOSI Governing Council, starting from our President Sonal Kalia, ma'am, as well as our incoming President and team, Divakant Mishra, sir. Ma'am, you have set the bars too high, and I think we'll all do it together. As the going says, the YOSI going says, I can see the Retina Journal Club. I was just on and off listening to it. Thank you to Nupur ma'am and Anujit again for curating this wonderful session. And to all the people out there, be it Dr. Pavik, the monthly mentor, Dr. Ritika, Dr. Ruchir, Dr. Karthikeya Singh, who's still here, and Dr. Rohit Modi, of course, Divakant sir, and all the J's team, also the Journal Club team. So yes, ma'am. So as you rightly said, it's just a transition, and I hope people who are watching it, I hope all of you would have filled the Google Forms as well. The idea is to bring up many new faces, unearth more new talents. So I think I would just take this opportunity as Nupur ma'am is sharing the screen once again. So you can see this is from the desk of the Journal Club team. So it's a team that we are coming up with for the next 2 years. So we also made sure that the previous team is well acknowledged with an innovative QR code that you can see. By scanning this QR code, you can see all the work done by the previous team, which will lead you directly there to all the Journal Club up to this one that you are currently seeing, which will also be uploaded there. You can also be a presenter, panelist, monthly mentor, and a research expert. So get on and start filling your forms. You will be seeing this in your mailbox yesterday. And I think let the team do the talking, as Nupur ma'am and Anujit, as Sonal ma'am, and all the team YOSI members have set the bar high, and looking forward to your guidance. So we are starting with one IGO live wire concept on August 13th with Dr. Vanati ma'am, IGO editor. And of course, Anujit is still part of it, and Nupur ma'am is also still very much part of it. So it's just a small transition, which we will be taking it with the guidance of all the PO mentors and the team YOSI. Thank you, ma'am, for giving this opportunity to make our viewers who are watching it to fill the Google Forms, so that we will just be continuing it the way forward. Thank you, Nupur ma'am. Thank you to the whole YOSI team, the President, Secretary, and all the Governing Council team for giving the opportunity to take it forward in a much positive and a very energetic way. Thank you, ma'am. Thank you.
Thank you, Dr. Prasanna. I'm sure that, YOSI Journal Club could not have been headed by a better person than yourself. And I look forward, now from the other side of the, from being a moderator, now probably, would like to participate as a monthly mentor or as a panelist. And I look forward to my participation in Journal Club session in a different role with you as the head. So this is probably for the last time I'll be sharing this screen. Thank you all so much. Thank you to all the people who are watching this. Thank you to all the people who were involved in the Journal Club session today. Thank you, Anujit. I can never say any sort of thanks to you is just too short. It's not enough for whatever you've done for the Journal Club, and the friendship and the camaraderie that we have shared is too good. So that is one thing that I would like to say. People, YOSI is not just about, it's not about just getting involved in things. It's also the friendships and the camaraderie that you create that, that last for a lifetime. And so the email ID would remain the same. There'll be a transition. Dr. Prasanna will be handling it. So as Dr. Prasanna said, that the Google Forms will be shared shortly, and it's already been shared on your mails. He'll be sharing it on the WhatsApp group. You can immediately fill the Google form, and also put a direct mail to this email ID if you wish to. And with this, we call this a wrap. Thank you once again to all, to the presenter, to all the panelists, to all the audience who've been watching us. Thank you so much. And with this, we
Thank
call
you.
this a wrap.
Nupur
I
ma'am.
will end the live.